Yes, thank you very much for the welcome, and it's great to be back in London. I've not been here for about 3 months, survived the underground, getting up at 5 o'clock with not too many stroppy people, and I'm really excited about this screen down there that gives me 14 minutes 50 seconds remaining. I was doing a talk last week on sort of prison-related issues, and said you got 15 minutes, and after 5 minutes, the thing went to the back saying you got 5 minutes left. I thought, no, I'm not a mathematical modeller unlike the next speaker. I thought 5 and 5 makes 10, I'm sure in my world, not 15. Of course, they were trying to chip back on my time, so I feel really reassured by this. It feels very scientific. Anyway, let's whiz through prisons, which is my abode at the moment. Been working there for about 7 years. This is a very wordy slide to kick off. But just to show you the scale of the problem, the key thing from this slide is Singleton et al. 1998, in that it really is 12 years since we got some really good prevalence data on the level of drug misuse in prisons. But this was the last sort of national survey, and basically there's a lot of it around. More closer to home if you live in London, and also more closer in terms of time. In 2006, Fazal et al. Have done a really nice systematic review of prevalence studies for drug dependence, and as you can see, still a lot of drug misuse around. So we're in the right place. We want to address some of these issues. It's an interesting one. Does prisons increase risk? It certainly increases mental health risk. Does it increase physical health risk? Difficult, because injecting certainly reduces in prisons, but as our last speaker says, there is more risky injecting of those who do inject. So the smaller population that injects, more risky. And it has been shown to be a science of initiation into injecting. So is there an absolute risk reduction in injecting in prisons is an unanswered question. Around 7% of the prison population, Hep C positive. There's an association with number of times in prison and antibodies to Hep C and Hep B, but of course the $6 million question is again, is it a risk place for incidents of Hep C? Avril Taylor, who some of you will know, a real leader in the field, currently doing some very nice piece of work around looking at incidents in prisons. And for those of you who are real scientific methodologists, I was speaking to just on the phone a couple of weeks ago, and she said, yeah, we're just going to do it on the spot test. I said, this is amazing. I thought incidence, you had to, by definition, incidence is a prospective cohort study design. She goes, no, what we're going to do is we're going to exclude anybody who's not, they have to, the inclusion is they've got to be in for the window of turning positive. Then we're going to do a spot pinprick test to see who's Hep C positive, which is a really nice piece of design to just sample once and to get some really good incidence data. So it's a rapidly moving field and an exciting area to be involved in. We talk about criminal justice and health, and there's always something going on in prisons. There's always a political angle. It's just the way it is. As a society, we have a morbid fascination with prisons, and the tabloid press even more so. So this feeds part of the electorate. Can make it a bit of a tricky place if you want to get into politics, or if you find yourself in politics, don't want to be there, because you have to keep the electorate happy. But we have moved on in prisons, as you can see from this slide. Cast your mind back about 100, well, I was going to say 120 years, but it's not that long since before contraception, but certainly 120 years ago there wasn't contraception as we know it now. So if you were a Victorian unmarried mother, you faced an impossible dilemma during the 19th century. Most employers would turn them out as soon as their condition, which was pregnancy, became obvious, and then it was the workhouse or often unsympathetic relatives. After they gave birth, few would employ a mother and child, and lodging your child with a nurse cost money. And they're talking about this lady Emma, saying who was charged for murdering a child at birth, and it was saying the saddest aspect was that it wasn't that unusual. That same year, Anne Noakes of Reigate was charged with murdering her baby son. In 1894, Minnie Walls was tried for killing her twin daughters. And if you're remotely interested in criminology, what you'll find is that Britain's largest mass serial killer, mass murderer, was not somebody in recent times who we would think would spring to mind. It was actually a lady who for money would murder children at birth. Of course, contraception came along, and really, if you look at it in public health terms, contraception has been a massive improvement in women's health. And certainly, it does show, though, how health and criminal justice will always be partners, often in a shotgun marriage, often uneasy, but it is the reality of where we work. So then, what are the barriers to health in prison? Well, social isolation is a critical one. I really enjoyed Geraldine's first talk because I didn't put my hand up when he said he's a proper doctor in the house, because I don't make any pretense to be a proper doctor. I fiddle around in general practice. I do a whole day a fortnight, and I had the joy of doing that day yesterday. It really was a joy, seeing what some call proper patients. And I have to say, a lot of times, a lot of it around at the moment, viral illness. So I don't know what the strain is of the viral illness going around at the moment. I'll ask our public health colleagues and try and get back to you, David. But I do know there's a lot of it about, and with time, not antibiotics, bit of rest, bit of TLC, we tend to come through it. But anyway, in prison, as Geraldine was saying, mental health, are these people really going to go on 2 bus journeys to the biochemistry lab and wait for a blood test when they perceive themselves to be not that well, and actually going to the lab test makes me feel more paranoid. It's actually the same in prison. We ignore sociocultural factors and its impact on health at our peril when we're in prison, because social isolation, many prisoners are held a long way from their homes, particularly in the female estate, where it's only 5% of the prison population are female. So that's a tricky area. There's less prisons, therefore you have to travel further, less chance of visits. Parenting issues, over 33% of women prisoners have children under the age of 5 when imprisoned. Only 5 of these remain in the house. So how are you really going to address your Hep C when you've got all this going on in your life? As Ash just said before, is it a time to wait, sort some of these issues out before you get treatment? So I'm going to argue that's not the case for all prisons, hopefully, in a couple of minutes. Large throughput, again, we have been poor in prisons. A lot of it is skill mix. If you have a scrape with the GMC or the Nursing Medical Council and you're clinging on to your job, it's not happened to me. Hopefully not yet or not ever. But sadly I have come across a lot of doing a lot of expert witness reports where there have been clinicians under review by the GMC, under monitoring by the GMC, and committed errors whilst working in prison. So we have a massive issue around skill mix, confidence, competence in prisons. And added to that is this large throughput where I often say to our clinical staff, you have to wear a few hats in prison. It is primary care, but it's only primary care for the routine work that's coming through. On first night reception, put an A&E hat on. It's more an A&E model, but large throughput patients, 30 plus patients coming through. You have around 2 hours to see these people with a high level of physical health need. Is that the right place to screen? It's certainly the right place to meet acute health need. So we have to sort of multitask both in our minds and in our practice in prisons. And this large throughput, particularly in remand prisons, really is a barrier for Hep C treatment. A punitive culture, a sense of distrust, lack of empathy, fear of being diagnosed with mental illness. A really nice article in the BMJ by Howard and al. showed this, and how this punitive culture infects us as healthcare staff, so we have a duty of care. But it's very difficult, even small things like calling in patients by their first names, which happens, when I'm in practice. Yesterday I'd either say hello Margie or hello Mrs. Notes or something, but I don't say Notes, come in, or Jones, come in to the surgery now. And this is the sort of culture that sometimes we're up against in prisons. Budgetary constraints, we're in the credit crunch, thank God we're here for a conference, will this become next year, and everything is online. But it's causing high level of purposeful activity, leading to an increased risk of suicide. We have budgetary constraints in Hep C, and that we're told that we can start our 9th patient this year on antiviral treatment whilst resident in prison, because we've been back to the commissioners and they've given the go-ahead. 2 more people can start on Hep C treatment. So there was how many tens of thousands was it? We're contributing to the hundreds again, or the tens at least. But that's the pyramid that we're stuck in.